So in this video, we'll continue with the series of neonatal jaundice discussion, where we'll see investigations, treatment, discussion, theory, and viva questions. So at the end of the first two videos, we were able to diagnose this as a case of either physiological or pathological newborn jaundice, whether it was conjugated or unconjugated jaundice, whether or not there were signs of bilirubin encephalopathy with the bind score, and what the most likely etiology of the jaundice was. So once we have diagnosed the case and we're able to give a summary, what are the common viva questions that come after that? So the first one being, what is pathological jaundice? So difference between physiological and pathological and causes of both. Although we've covered this in the previous two videos, there's one point that I really wanted to stress on that I haven't covered in the earlier videos is, what do I mean by breast milk jaundice and breastfeeding jaundice? They both sound very similar, but they're totally different. Although both of them happen because of increased enterohepatic circulation, let's look at the difference between the two. So what is breastfeeding jaundice? We look at this first because it's way more common. Okay, so it's seen in about 10 to 12% of newborns. It's basically because of lactation failure. So because the child is not able to receive enough amount of milk, that's the reason why they're at increased risk of breastfeeding jaundice. So what happens is that when there's decreased intake of milk, there is slower bilirubin metabolism, decreased production of meconium, gut hypomotility, and as a result of which, because the bilirubin is not able to excrete out of the body in the form of stools because of inadequate formation of meconium, because of delayed feeding, that bilirubin in turn uh, is broken down in the bowel and re-enters the enterohepatic circulation, and the bilirubin tends to stay in the bloodstream, which increases the risk of jaundice. So it's basically increased enterohepatic circulation because of lactation failure. Now, when you have a child clinically, when you're suspecting breastfeeding jaundice, it's pretty much a diagnostic exclusion where you've ruled out the other causes, and then you have a history that the child is not feeding well. There's significant weight loss. Along with that, on examination, you will also see dehydration. So the child has weight loss, is has poor perfusion, has delayed CRT, maybe sunken anterior fontanelle, looks lethargic. And when you do your labs, you will see hypernatremia. Okay, so they have hypernatremic dehydration along with weight loss. So all of this is because of lactation failure. And how do you treat this jaundice? You treat the cause. So you ensure correct breastfeeding practices, and that's how over time your breast feeding jaundice gets corrected. So you know the cause, it's lactation failure, and that's what you target when you're trying to treat it. On the other hand, you have another entity called the breast milk jaundice. Okay, so that's again way less common, seen in hardly 2 to 5% of newborns. Breast milk jaundice starts by about 3 to 5 days, peaks at about 2 weeks, and returns to normal by about 4 to 12 weeks. Now, what is the etiology behind breast milk jaundice? So, what happens is there's a particular factor in the human milk that's known as beta glucuronidase or pregnanidiol, both of them. What happens is these factors causes deconjugation of the bilirubin in the intestine. So what happens is in the liver you have conjugation of bilirubin, where the UGT1A1 enzyme helps in converting the indirect bilirubin to direct bilirubin, which ideally would then be excreted out of the body. But the human milk has factors like these two, which results in deconjugation of the conjugated bilirubin. So what is left behind again is the indirect or the unconjugated free bilirubin, which re-enters the enterohepatic circulation and again stays in the bloodstream, causing jaundice. So this is why why the baby is at a risk of breast milk jaundice. Again, this is very less common, but and a diagnosis of exclusion. So when everything else has been ruled out, this probably could be the diagnosis as to why the baby has jaundice. So whenever you're asked for causes, never utter the word breast milk jaundice, because that's way less common, and you need to rule out every other possible cause before you label the child to have breast milk jaundice. Okay. So this is the difference between the two. A lot of examiners like to ask this. The two are pretty similar sounding terms, but they're very different. Okay. So another vital question is, so at what level of bilirubin can you clinically appreciate jaundice? Okay, so when the total serum bilirubin is more than 5 milligram per deciliter in a newborn, or more than 2 milligram per deciliter in older kids, that's when you can actually see bilirubin clinically as yellowish discoloration of the skin, sclera, etc. Okay, and another question is, let's say you have a baby who is small for gestational age. Okay, low birth weight, small for gestational age, and that child also has jaundice. What are your differentials, or what are you kind of thinking of? So it could point towards an underlying torch infection. Okay, so when you have torch, you have growth restriction. Maybe that's the reason why they are small for gestational age, and they have other comorbidities. They may have hepatosplenomegaly, skin petechiae, microcephaly, cataracts, chorioretinitis, etc. So that is one differential that you need to keep in mind when you have a small for gestational age baby with jaundice. And other differential could be because of polycythemia. Let's say you have a baby who, the mother who had severe preeclampsia. That severe preeclampsia causes uteroplacental insufficiency, as a result of which the baby does not get enough blood, enough oxygen. So the baby's body kind of tries to compensate by increasing the production of hemoglobin, causing polycythemia. And that again, when you have polycythemia, you have more RBC volume, RBC mass, and when those RBCs become old and undergo hemolysis, the increased risk of jaundice. So these are two important differentials to keep in mind when you have a small for gestational age baby along with jaundice. Okay, so this is just to mention viva questions that can be asked. And we're moving ahead. What are the causes of conjugated or direct jaundice? Now, remember, conjugated jaundice is always going to be pathological. You can never have physiological direct jaundice. So, what are the causes? Most important, it has to be an obstruction in the bile duct and the pathway below. So, most common of that is biliary atresia, or you can also have choledochal cyst. Infections, both sepsis and torch group of infections, can cause conjugated jaundice. Certain metabolic conditions like PFIC, which is progressive familial intrahepatic cholestasis, alpha-1 antitrypsin deficiency, tyrosinemia, all of this, again, basic pathologies in the liver where conjugation is going on, and these can lead to conjugated jaundice. Parenteral nutrition. So when the child, let's say, is not able to take enteral nutrition, not able to feed, and for whatsoever reason is receiving parenteral nutrition, which is a combination of a lot of nutrients, where you add fat, like you add lipids, you add cholesterol, you add proteins, you add minerals, vitamins, etc. The lipid component of the parenteral nutrition can again increase risk of cholestatic jaundice. So that's one thing that you need to keep an eye on when the child is receiving prolonged parenteral nutrition. And again, congenital hypothyroidism can lead to a combination of both conjugated and unconjugated jaundice. So these are again viva questions are what are the causes of direct or conjugated hyperbilirubinemia. Next set of questions is what are the causes of prolonged jaundice? Now, what do I mean by when I say prolonged jaundice? When the jaundice persists for more than 2 weeks in a term or more than 3 weeks in a preterm child, that's when you label the jaundice as prolonged jaundice. And prolonged jaundice is always pathological. So again, causes can be, like we've seen before, categorized as increased bilirubin production, impaired conjugation, or increased enterohepatic circulation. So you can have hemolytic jaundice, congenital hypothyroidism, concealed hemorrhages as either cephal hematoma or subcalial bleed, breast milk jaundice, breastfeeding jaundice. If there's infection, could be a UTI or a bacteremia sepsis. Obstructive causes surgical causes, biliary atresia, choledochal cysts, or impaired conjugation like Crigler-Najjar or Gilbert syndrome. Okay, so these are all causes of prolonged jaundice. Now, moving to the next set of questions, and clinically relevant, important stuff is investigations. So, when you have diagnosed a newborn as having jaundice, what are the first set of investigations that you will send, which will aid you in giving more clue as to what the underlying etiology and what exactly you're dealing with? So let's look at the first line investigations. And by first line investigations, I mean those investigations that you will send for all kids that you diagnose or you suspect to have newborn jaundice. So definitely the first one is going to be serum bilirubin. And in that, you look at both total, direct, and indirect components. So total bilirubin is what is the number that we kind of look at to categorize whether the child is requiring treatment or not. And when you break down the total jaundice as whether it's direct or indirect, it will give you an idea as to whether you're dealing with direct or conjugated hyperbilirubinemia versus indirect or unconjugated. Okay, so like we've discussed before, it's the indirect or the unconjugated free hyperbilirubinemia, which is the most common cause of newborn jaundice. But yes, when you have your serum bilirubin levels, you need to look at the total and the direct and indirect component, because both of them will give you different and extremely important set of information. Next is the blood group of the baby and the mother to look for any RH or ABO incompatibility. Next is if you're suspecting RH or ABO, which is again one of the most common causes of hemolytic jaundice in a newborn, you send a direct Coombs test to see if really dealing with incompatibility, and that's what is causing the hemolytic jaundice. And last but not the least, you will send a CBC with a peripheral smear. Remember, when you say CBC in your exam, only a complete blood count, which is going to give you your hemoglobin, WBC, uh, platelets, and hematocrit, is not going to be enough. What you really need is a complete blood count along with the peripheral smear, with the retic count and the hematocrit, because it's the whole thing. That's the whole CBC picture that will give you an idea of what is the underlying cause of jaundice. So let's look at what a peripheral smear would look like in a case of newborn jaundice. So on the left, you can see the slide, which is hemolytic jaundice. Again, both of them are hemolytic. The first one could be either an ABO or RH incompatibility, because what you can see here is the red arrow looks at spherocytes. Okay, so these are spherical RBCs. RBCs are normally a little elliptical, but these are spherical RBCs or spherocytes. You have nucleated RBCs, the yellow arrow. That means they are premature release of RBCs from the bone marrow into the circulation. And you have anisopoikilocytosis, so different shape and different sizes of the RBCs. So this whole picture, along with the fact that let's say the mother's blood group is O positive and the baby's blood group is B positive, this will give you an idea that, okay, yes, with the history given in the background of the possibility of an incompatibility, along with a peripheral smear showing all of these features, yes, most likely I'm dealing with a hemolytic jaundice of newborn. Similarly, if you're suspecting G6PD, what you would see on a peripheral smear are these bite cells. If you can look carefully, it looks like those cells are bitten on the side. And Haynes bodies. So what are Haynes bodies? They are tiny dots that appear in the RBCs when the hemoglobin is damaged because of oxidative injury. And we all know that G6PD deficiency results in oxidative damage to the hemoglobin, and that's what causes the hemolysis and the dark colored urine, and etc. etc. So this is what a peripheral smear in a case of G6PD deficiency and ABO or RH incompatibility will look like. Similarly, if you have or you're suspecting case of hereditary spherocytosis causing jaundice in the newborn, you will have a peripheral smear that will be full of spherocytes. So that's why when you're asking for a CBC, the peripheral smear becomes extremely important. And you have to say that you will look at this complete blood count, which will give you a value of your hemoglobin which will tell you whether the baby is anemic or not. Or if you're suspecting polycythemia, again, your hemoglobin and hematocrit will give you an idea of that as well. So your CBC will give you hemoglobin with the hematocrit. If the child is dehydrated, okay, and you're suspecting hypovolemia, like dehydration causing jaundice, like we just saw the breastfeeding jaundice, which was because of lactation failure. If you have that kind of a picture, then again, you will have hemo concentration. When I say hemo concentration, how do I diagnose it? Normally, the hemoglobin, and there's a ratio between the hemoglobin and the hematocrit. So normally the hematocrit should be thrice the hemoglobin. To give you an example, let's say if the hemoglobin is 10 gram per deciliter, normal hematocrit should be around 30. Okay, if you're suspecting that the child is dehydrated and that's causing the jaundice, then there'll be an increase in the hematocrit. So let's say hemoglobin is 10, hematocrit might be 40. So that will tell you that the blood is concentrated. That's because the child is dehydrated. There's hypovolemia, and that is maybe a precipitating factor for the jaundice. Now, what is the importance of a retic count? So the retic count will give you an idea whether there's ongoing hemolysis or not. So when you have hemolysis, that means peripheral destruction of the RBCs, the body tries to compensate by producing more and more RBCs. So your retic count, which is your reticulocyte count, which is like a precursor of the RBCs, the retic count will go up in a case of hemolytic jaundice. So let's say normal retic count is 1 to 3%. In a case of hemolytic jaundice, it may go to as high as 10%. So that again will give you an idea that okay, there's some amount of hemolysis going on, which has caused an increase in the retic count. So when you look at the CBC, we've discussed that CBC with peripheral smear, with retic count, and with hematocrit will give you a complete blood picture and will give you very specific and important points that will help you further in your diagnosis. So I hope this is clear as to what are the first line investigations that you will send for every child that you have with newborn jaundice. Now, next is the second line investigations that come into picture when you don't have enough information at the end of your first line, or if you're suspecting other pathological causes of prolonged jaundice. So, if you're suspecting congenital hypothyroidism, you send your thyroid function test. If you're suspecting sepsis, whether it's TORCH, UTI, or a bacteremia, you will send CRP, blood culture, or specific titers for the TORCH infections. If it's concealed hemorrhages, like the child has a scalp hematoma or a scalp swelling, and you think that is causing the jaundice because of an underlying cephal hematoma, then you do an ultrasound to rule out cephal hematoma or subgaleal bleed. If you think that the jaundice, or on the basis of your first line investigations, you've got a picture of jaundice, which is a direct or a conjugated hyperbilirubinemia, yes, you will want to look out for obstructive causes like biliary atresia, choledochal cyst, and that is when you will do an ultrasound of the abdomen. And lower down the list, again, less common causes would be metabolic, like alpha-1 antitrypsin deficiency, tyrosinemia, PFIC, or if you have Crigler-Najjar, rotors, etc. All of this will require a metabolic and even a genetic workup. So these are set of investigations that you will do as second line when you don't have answers with your first line investigations. Okay, I hope this is clear. Moving ahead with another concept which might be new to a few of you, or you might have even seen it being used in your NICUs and your postnatal wards. But this is something interesting, something that has been around for the past few years, and I'd like to mention that is the use of your transcutaneous bilirubinometer, or the TCB machine. Now, what is this machine exactly? How does it work? What are the benefits, and why are we even talking about it? So this is what the machine looks like. Okay, so this is the TCB machine. There's a little sensor over here which is pressed onto the skin, and the number that you can see, a 15.7, will give you an estimate of the serum, or give you an estimate of the bilirubin content of the body. So what happens is that the TCB machine measures the yellowness of the reflected light, which is transmitted from the skin back to this transmitter. And then once the light goes back, it uses an algorithm to predict the total serum bilirubin from the objective measure of the skin color. Okay, so basically, if you feel like if you want to assess the bilirubin level of the baby, but you don't want to send a blood sample or a serum sample, this is a you can say surrogate marker for the total serum bilirubin, where this machine has a sensor over here at the tip. So you press it on a bony structures, most likely on the sternum. And once you press it, there's a little light which blinks. And the reflected light that goes back into the machine is then assessed with the help of an algorithm. And it will give you, or it will display a value of this serum bilirubin. A lot of times what we do is we do uh, three values of the skin, and then we take a round off or an average of those three values, which is definitely more predictive than looking at just one single value. Okay, so it is said that there's a good correlation between the transcutaneous bilirubin and the total serum bilirubin concentrations. Usually there's a difference between the two of around 3 milligrams per deciliter. Again, that's more uh, sensitive when the serum bilirubin is less than 15. So as your serum bilirubin levels go on increasing, the correlation between a TCB and a TSB goes on decreasing. Okay. So, and again, this is not a foolproof method. So your total serum bilirubin concentrations that are measured with this machine depend on factors like the melanin concentration and the instrument being used. So the darker the skin color, the less reliable would be the estimation of bilirubin with this machine. And again, different machines from different companies use different algorithms. So there are a few that are said to be more accurate as compared to the others. So a lot of factors go into play in determining how reliable your values are. But yes, having said that, keeping all the standardized protocols in mind, yes, this is a very good surrogate marker for your serum bilirubin measurement. However, having said that, the total serum bilirubin should be measured if the transcutaneous bilirubin that is measured with this machine is more than or within 3 milligrams per deciliter of the phototherapy range for that particular child. Or if the or if the TCB is more than 15, then you should always correlate it with the serum bilirubin. So I'll just repeat it. If if your TCB machine is showing a value of more than 15, or the value showed by the TCB is more than or within 3 milligrams per deciliter of the phototherapy range for that baby at that gestational age, then your TCB value has to be correlated and confirmed by sending a blood sample and measuring total serum bilirubin. Okay, but again, using this kind of a machine in low resource settings, especially like the poorer developing countries where our postnatal wards are filled with like 50 or even 100 kids at a time. Sending serum samples for all is not possible logistically, and why would you want to prick every newborn just to send a serum bilirubin? So this is a good estimate of the serum bilirubin, definitely better than your Cramer staging, which is a crude visual inspection to look for the yellowness of the skin, which will give you an idea of the jaundice. But yes, it's it's been there around for years and definitely adds to some value. But a more predictive and a more reliable method would be using the TCB machine. If not, and certain conditions where you have to confirm your TCB with a serum bilirubin levels has to be kept in mind, and you cannot totally and just only rely on this machine. So this is some interesting thing that has been going around for the past several years, and I wanted to mention about it. So if you have any questions about how it's used, what is the mechanism, you can put it in the comment section, and I will try and elaborate it more. Now coming to treatment, so you want to strike a balance between treating the jaundice in a way that you're preventing severe hyperbilirubinemia and preventing your neurological complications like the bilirubin encephalopathy. But then at the same time, you do not want to give unnecessary interventions because then that will interfere with the bonding of the baby with the mother and even with the breastfeeding. So you have to strike a balance between the two to provide maximum benefit and cause minimum harm. So what are the two most common treatment options available when you want to treat newborn jaundice? So this is something that we all are aware of. Phototherapy and exchange transfusion are the two uh, mainstays of treatment for neonatal hyperbilirubinemia. Now, let's look at each one in detail because these are questions that will be asked definitely if you have a newborn with jaundice, that what are the treatment options? A lot of questions come on phototherapy as what is the mechanism, what kind of lights are used, what is the wavelength used, how are the phototherapy lights designed, when do you start a child with phototherapy, when do you stop? And so we'll be looking at all of these things in the next few slides. Phototherapy is another important short note, can come as a long question if you have like a question on newborn jaundice. So, and again, it's really interesting as to how this concept of phototherapy actually came into practice years back. So we'll look at that as well because it's very important to know the origin and where things started to actually get the hang of how things have progressed over the past so many years. And it's really interesting to see how science has moved ahead in like the past few years. So we look at phototherapy. This is a link that a blog I would say that I had written on Twitter on uh, phototherapy as to how it started and how it's used. So we'll just look at that for you all to understand uh, what phototherapy is all about. I hope you can see my screen. Okay, so uh, identify this wonderful lady who revolutionized neonatology. So this is Sister Jean Ward, who is a British nurse who was in charge of the premature nursery at the Rochford Hospital in the UK. And it was Sister Jean who is we owe the discovery of phototherapy to her. Now, how did it start? So it was in as early as 1956 that during their ward rounds, a preterm baby looked pale yellow except for a strongly demarcated triangle of skin on the leg, which looked much yellow as compared to the rest of the body. So it was Sister Jean, who explained that this was a jaundiced baby who had been exposed to sunlight. Okay, so that's the reason why the rest of the body looked pale yellow. But what was the reason that the little area on the leg was still way darker as compared to the rest of the body? So that was because a corner of the sheet, the bed sheet, had covered that area of the baby's skin, whereas the rest of it seemed to have faded because they had been exposed to sunlight. However, a few weeks later, it's the same baby who required exchange transfusion. And what happened is before they started exchange transfusion, they collected pre-transfusion blood samples, but then somehow that sample got misplaced. And later, it was that sample that was located near the windowsill and the serum of that uh, pre-transfusion or pre-exchange transfusion sample, the serum was green instead of yellow, and the bilirubin content of that blood sample was way below expected. So they were expecting the serum bilirubin of that exchange transfusion blood sample to be really high because that's the reason why the baby really even required exchange. But what they found was that the serum had turned green, was no more yellow, and the bilirubin content was way lower than expected. So it was exposure to sunlight that had reduced the bilirubin content of the sample because the sample was lying at the windowsill and had been exposed to sunlight. So that's how they stumbled upon the discovery, not knowing that it would be effective for millions of kids all over the world, even after 50 years. So even today, phototherapy is being used left, right, and center in all our NICU and postnatal wards. And it's Sister Jean who really is Hagdar of all of this discovery. So let's look at how phototherapy works. So when the bilirubin in the skin and subcutaneous tissue absorbs light, it undergoes several photochemical reactions which generate isomers of bilirubin and low molecular weight derivatives, which are then easily excreted in the bile or the urine without the need for conjugation. Okay, so when you have light falling onto the bilirubin in the body, it gets converted to a lot of these bilirubin isomers and smaller components, structural and configurational isomers like lumibilirubin, 4Z bilirubin, etc., etc. And all of these products get easily excreted out in the stool and the urine without the need for conjugation. So it's easy elimination of this bilirubin, which in turn helps in treating the jaundice. So that's how phototherapy really came into existence. And uh, yeah, that's the story about. Oh, okay. So moving ahead with how practically we use phototherapy. So when you decide that a kid is going to require phototherapy is when you look at these American Academy of Pediatric clinical guidelines. So they have got charts to decide which baby at what gestational age, at what level of bilirubin will be requiring phototherapy. So let's look at these charts. On the x-axis, you have age in hours and days. On the y-axis, you have the total serum bilirubin. And along with that, you have these different graphs for different gestational ages. So you have two charts. One on the left is phototherapy thresholds for those kids who do not have any neurotoxicity risk factors, whereas on the right, you have a chart for those kids who have more than one neurotoxicity risk factors. Okay, so what do I mean by these risk factors? So there are five of them. If the newborn has any kind of hemolytic jaundice, whether it's Coombs positive, ABO-RH incompatibility, G6PD deficiency, or others, then that accounts for a risk factor or a neurotoxicity risk factor that the baby has. Gestational age less than 38. So the smaller the baby, more is the chance. If there is clinical instability in the past 24 hours. So that means the child has been clinically unstable, whether it's because of the respiration, circulation, etc. That again increases the chance of bilirubin neurotoxicity. And sepsis and hypoalbuminemia. So when your serum bilirubin, serum albumin, sorry, is less than 3 grams per deciliter, all of these five causes are risk factors for neurotoxicity because of jaundice. So when your baby has any of these risk factors, keeping aside the gestational age, okay, so keeping aside this one risk factor, And taking into account any of the other four, you have different charts for different age groups. So let's just take an example. Let's take uh, a 72-hour-old baby, that's a 3-day-old baby, who was born at 39 weeks without any of these risk factors with a serum bilirubin of 19. Okay, so let's look at 72-hour-old, and I'm going to look at 39 weeks. I'm going to look at the yellow line. Okay, so 72 hours, 19 falls somewhere over here. So it's just about 19. Okay, so maybe 19.5 is the threshold for starting phototherapy for this baby. And at present, the serum bilirubin is 19. So it does not fall under the category of starting phototherapy, but it's a very gray zone. It's pretty close. And you at least need to keep this baby on a very strict, regular follow-up. I mean, follow-up in terms of like regular assessing the child, because he might anytime fall under the category of needing phototherapy. So these charts are used depending on the serum bilirubin and the gestational age. Let's say similarly, there is a 35-week baby who has respiratory distress syndrome, has acquired surfactant. So basically clinically unstable in the last 24 hours. 35-weeker, 96 hours old, so 4-day old, with let's say a serum bilirubin of 16, or let's say serum bilirubin of 20. Okay, let's take it on the higher side. So 96-hour old with serum bilirubin of 20, definitely, yes, the baby is going to require a phototherapy. Okay. Okay, so these are the two different charts that you will use for assessing which baby is going to require phototherapy at what range. Now, having said that, these charts are used only for kids who are more than 35 weeks of gestation. We have different charts for babies who are preterm, less than 35 weeks, both for phototherapy and exchange transfusion. The reason why the charts for a 35-weeker are or less are different is because they are at a way higher risk of having newborn jaundice and its associated complications, because they have brain immaturity. So there is what do you say? An incompletely or a weak development of the blood-brain barrier, which increases the risk of your bilirubin crossing the blood-brain barrier and entering the CNS. So that increases the risk of jaundice. Along with that, if you look at the bilirubin staining in a preterm brain versus a term brain baby, in a term brain, you will have more classical topographic uh, bilirubin staining affecting more of the basal ganglion, cerebellum, and the deeper structures. Whereas in a preterm baby, less than 35 weeks, you would have more diffuse bilirubin staining affecting a lot of brain structures. And definitely they are sicker. They have other comorbidities. They might have associated inflammation, sepsis, instability. So that's why we cannot use a chart for a 40-weeker as that for a 35-weeker, because we need to consider all the other comorbidities and other associations. And that's why you have different charts for those babies less than 35 weeks and those more than 35 weeks, depending on whether or not they have your neurotoxicity risk factors. Now, talking more about phototherapy devices. So, basically, the kind of light that is used is important. So, you use the blue-green light in a particular spectrum, which is 470 to 475 nanometers. It's a narrow range spectrum. The reason why we use this particular wavelength is because bilirubin absorbs maximum light in this specific range. What we want to achieve is a maximum irradiation or intensive phototherapy to achieve an irradiance of 30 microwatt per centimeter square per nanometer. So for the 30 number, and for the irradiance, we look at the wavelength of light being used, intensity. So the intensity of light depends on the light source or the kind of light that you're going to use to give phototherapy, and the distance between the light and the baby. You want to keep minimum distance so as to give maximum irradiance. Uh, Make sure to illuminate the entire body, I mean, maximum surface area, just making sure to cover the genitals and the eyes while the baby is receiving phototherapy. So basically, just put a diaper and an eye patch, and the baby needs to be naked. And different sources of light that can be used for phototherapy are the blue LED lights, which are the best in terms of both effectivity and even power consumption. You can also use fluorescent light bulbs, halogen white lights. Fiber optic or billy blankets, like you can see over the babies, like wrapped around in a blanket which is having a light source, or billy pads. But having said that, still the most common source of light being used is your blue LED lights. Now, while giving phototherapy, it's important to ensure maximum surface exposure, uninterrupted exposure for maximum time, cover the genitals and the eyes, and ensure breastfeeding. So the only disruption in the phototherapy session should be when the baby is taking the when the mother is taking the baby out of the phototherapy unit to breastfeed, calm the baby down, feed, burp, try and put him to sleep, and then put him back into the crib which has the phototherapy source attached. So you have to ensure that the baby is receiving phototherapy, but then at the same time is also being fed well. Because if you have an imbalance between the two, let's say the mother is wanting to keep the child in phototherapy as much as possible, and in the same time not feeding well, then that's not going to solve the purpose. So you have to again counsel the mother regarding phototherapy and its importance, and trying to keep the baby as long as you can in the phototherapy unit, but at the same time not compromising on the breastfeeding, because you want both to happen together. Okay, so what are the complications of phototherapy? You can have dehydration, weight loss, and both of these conditions specifically when there is an imbalance between the feeding pattern and the phototherapy. Bronze baby syndrome, retinal degeneration. Sometimes kids develop reddish macules and diarrhea. So by bronze baby, it's basically it's like a dark bronze colored discoloration of the skin that is thought to happen because of impaired excretion of the phototherapy products in a case of direct jaundice when that baby has received phototherapy. And it's a very benign complication. The skin discoloration tends to wean off in the next few weeks. Diarrhea, I've said it's good because if there's good bowel movement, that means the meconium is being excreted well. That means all the bilirubin, all the isomers that are being produced in uh, the body because of phototherapy, that have a way of being excreted out of the body. So obviously, by diarrhea, it should not be something which is liquidy and uh, so frequent that the baby is getting dehydrated. But yes, good bowel movements and at the same time ensuring good feeding is a good sign of phototherapy. Now, while giving phototherapy, yes, you have to monitor vitals and the hydration status. Repeat serum bilirubin, because once the child has been put under phototherapy, you cannot use the transcutaneous bilirubinometer, which was used to assess the skin yellowness, because the skin tends to get bleached because of the phototherapy. So once the child has received phototherapy, if you want to monitor the serum bilirubin trends, you have to send a blood sample and get the serum bilirubin. So you'll follow serum bilirubin within 12 to 24 hours, depending on a lot of factors like the age of the child, age at which phototherapy was started, what was the baseline while starting phototherapy. Definitely, if the child is having very high bilirubin levels, and you will measure them more frequently versus somebody who's just fitting into the range of phototherapy. So a lot of factors go into play as to how frequently you'll monitor, but yes, on an average, you will repeat a serum bilirubin 6 to 12 hours after starting phototherapy to see the response. Yes, again, next very important question, when will you discontinue? Everybody knows that you need to start phototherapy when you plot the things on that chart. But then when do you stop? That's again something that we all need to know is now when the baby does not have rebound risk factors. Now, what do I mean by rebound risk factors? Risk factors like if the baby is less than 38 weeks, has hemolytic jaundice, or has required phototherapy within the first 48 hours of life. All of these factors increase the risk of rebound jaundice. By rebound, I mean that the moment you start phototherapy, within the next few hours, the baby will have an again increased spike of serum bilirubin levels. So if the baby does not have any of these risk factors, then when the serum bilirubin falls more than 2 milligrams per deciliter below the threshold at which the phototherapy was started, then you can stop it. Let's say phototherapy was started at 16, total serum bilirubin of 16. When the serum bilirubin falls to say 13.5, which is more than equal to 2 as compared to 16, then you can stop phototherapy. But if the baby has any of these risk factors, then only when the serum bilirubin falls to below 12 is when you will stop it. Okay, so this is again something very important practically, that you should know when to start and when to stop so as to give maximum benefit and cause least harm. This is a table mentioned in the American Academy of Pediatric Guidelines as the risk factors for developing significant hyperbilirubinemia. So, lower the gestation age, jaundice within the first 24 hours of life, pre-discharge TCB in the phototherapy threshold close to that range. If there's any cause of hemolytic jaundice, phototherapy before discharge. If the parent or a sibling has had phototherapy or even exchange transfusion, family history of inherited blood disorders like G6PD, etc. Exclusive breastfeeding with suboptimal intake, which is increasing your risk of breastfeeding jaundice. Any concealed hemorrhages, significant bruising or hematomas. Down syndrome and macrosomic infant of a diabetic mother who has polycythemia. All of these are significant factors for hyperbilirubinemia. Now, moving on to the next treatment option, which is exchange transfusion. So, again, this is something that, again, a lot of newborns, not a lot of, definitely a few newborns will require as a treatment option for jaundice, but it should be our aim so as to pick up and treat jaundice way before it reaches or comes to the threshold that it is going to require exchange transfusion. Having said that, I'm not saying that kids will not. There are certain kids, especially with the hemolytic jaundice, that progresses very rapidly and will require exchange. But this is a slightly risky procedure and can to be able to identify jaundice at the right time, give phototherapy, which is a safe and preferred first line treatment, and try to avoid going to the stage where the baby might even require exchange transfusion. So indications, if there's any sign of acute bilirubin encephalopathy like lethargy, shrill cry, opisthotonus, seizures, uh, hypotonia, poor feeding, etc. All of these are indications for exchange transfusion. Rising serum bilirubin despite adequate phototherapy. And if the serum bilirubin is within 2 milligrams of per deciliter of exchange transfusion, you have to be very fast in being mentally and physically prepared for the procedure of exchange transfusion. So these are the charts. Again, you have two charts, one for those who have risk factors, one for those without. And you have to plot again depending on the age and the serum bilirubin to decide which baby is going to need exchange transfusion. So what is the procedure in an exchange transfusion? So what we do is a double volume exchange transfusion. What do I mean by that? Is that 85% of the baby's blood volume gets replaced. So how do we do it? We establish uh, two catheters, one in the umbilical artery and one in the umbilical vein. So we all know that the umbilicus has two arteries and one vein. So we put an umbilical arterial catheter, UAC, and umbilical venous catheter, that's UVC. We extract blood through the UAC. Okay, so baby's blood comes out through that. And at the same time, we replace equal amount of blood through the umbilical venous catheter. So basically, you are removing all of, not all, but 85% of the baby's blood and replacing it with new blood. So definitely, this is something that is not going to come without its complications. So complications of exchange transfusion include hemodynamic instability. So you can either have hypovolemia or hypervolemia, hypercalcemia, hypocalcemia, hyperkalemia. It shouldn't be hypercalcemia. I'm sorry. It should be hyperkalemia, hypocalcemia, sepsis, fluid overload, hypovolemia, and all of these complications again increase your vicious cycle of having to treat jaundice along with all of the clinical instability. And that's why it's a risky procedure. But having said that, there will be kids who might require this, and it is often a life-saving procedure. So this basically covers the two main treatment options for uh, jaundice, which is phototherapy and exchange transfusion. All of the points that I've covered are viva questions, theory questions, MCQ questions. So please kind of go over all of these things again. And once we've discussed this, there's one question that I'm sure a lot of us will be asked by family and friends, that should we use sunlight to treat jaundice? The answer is a straight no. Latest recommendations do mention that direct sunlight is not recommended because it increases the chance of UV radiation, sunburn, hyperthermia, hypovolemia, dehydration, and later, less common, but yes, you cannot completely rule out is malignancy. But yes, keeping that in mind, certain advances in terms of especially using filters for developing and resource limited settings. So this picture on the right is from Nigeria, where a project was conducted by Stanford, where they used these special canopy filters that were made of a particular material that blocked the ultraviolet radiations and allowed light of a particular wavelength to follow below. And under these canopies, you can see the mother sitting with their newborn kids. And this was like an indigenous or a cheap way of providing phototherapy in areas that cannot afford the LED lights and the phototherapy units. And this has shown to be beneficial. It did not have any significant complications, and this was a successful project. So although direct sunlight is not recommended, a lot of technology and a lot of advance is being done in terms of what can what jugadu technique that can be used in resource limited settings with minimum money but providing maximum benefit to these kids, because jaundice is a very preventable and a very treatable condition, and there should be no baby who's dying because of newborn jaundice in 2024. So that concludes our discussion on jaundice, which was covered over 3 videos. I hope you found the content useful. If there's anything that you did not understand, you want me to cover again, any questions, any comments, any suggestions, you can definitely put it below in the comment section. Thank you for watching the video, and see you soon with another discussion soon. Thank you.